All right. Well, thank you for joining us today. My name is Heather Robidoux, and I'd like to welcome you to the Fayetteville Public Library this afternoon. I would also like to welcome those viewing the live stream from home. Just a quick note, we do have some feedback forms in the back. Please share your thoughts on the program today, and especially on programs and topics you would like to see in the future. That feedback really does help us build out future programming. Today's talk is the first in a medical topic series scheduled for 2025 that the library is proud to offer with UAMS Odyssey Clinic. This series will feature doctors, social workers, and other professionals presenting valuable information on a variety of health-related issues. And coming up, February 14th, heart health, appropriately, and then March 14th, understanding migraine. So with that, it is my pleasure to introduce our speakers today, Elizabeth Demoret and Craig Jones. Both are licensed social workers with the UAMS Odyssey Clinic, Elizabeth based here in Northwest Arkansas, and Craig in Little Rock. They are here today to help us understand schizophrenia, diagnosis, treatment, support, and more. So with that, thank you both for being here, and I'll turn it over to them.
Hi, and thank you for joining us today. We're really excited to be here to bring awareness to the schizophrenia diagnosis and to also share about support options, treatment options, and things of that nature. So like Heather mentioned, I'm Elizabeth Demoret. I've been a licensed certified social worker for about 8 years. Most of that has been in inpatient settings, working with individuals with serious mental illness. And then Craig Jones is also a licensed certified social worker. He's been a social worker for about 18 years, has a lot of varied experience, working, I believe, inpatient, outpatient, crisis services, all kinds of things. So I am the program manager for the Odyssey Clinic in Northwest Arkansas, and he's the program manager for the clinic in Little Rock. And the Odyssey Clinic is a coordinated specialty care clinic for first episode psychosis. So before we get too far into our discussion today, I just want to share an illustration of someone with schizophrenia. People with schizophrenia do vary, and their experiences and symptoms vary greatly. So this is just one example. So Tim was a 20-year-old senior in college studying computer science. He lived alone in a dorm on campus and had several close friends at college. He had always excelled in school, taking several courses for college credit while he was still in high school. However, during his last semester of college, studying became exceedingly difficult. He no longer could concentrate on his coursework, and his grades had shifted from A's and B's to C's and D's. He became preoccupied with beliefs that he was being poisoned. He also believed government officials were out to get him and believed that his phone was bugged. Due to his fears, he began isolating more and stopped eating in the cafeteria. He became very vague in text messages and phone conversations to friends and family. His parents noticed that Tim had become distant and thought he may be struggling with depression. He began having difficulty with normal everyday activities like brushing his teeth and stopped playing video games, which was something he used to enjoy. He began hearing voices telling him that he was being followed and to watch out. His friends were worried about him, noticing that he no longer responded to their texts and was rarely attending classes. His mother and father were also growing concerned that their son was not answering their phone calls and had stopped coming home. They asked his friend Joe to go check on him, and Joe found Tim's dorm in complete disarray. Tim seemed to be emotionless and gaunt. He had almost completely stopped eating as his fears of being poisoned increased. Upon hearing this news, his parents took him to be evaluated at a hospital. He spent several days on a psychiatric unit where he was evaluated by a psychiatrist, and he was eventually diagnosed with schizophrenia. So that is just an example. And we'll get more into symptoms that people tend to experience with schizophrenia. So it's a serious mental health condition with symptoms that fall into 5 categories. So some of the main ones that we may think of with schizophrenia include hallucinations, delusions, and disorganized speech and behavior, people can also have negative symptoms. And in the following slides, we'll get more into what each of those are. So hallucinations are perceptual-like experiences that don't have an external stimulus. So when we think about, we hear a sound, that is coming from somewhere else. So people that experience schizophrenia, it's a very similar experience and it feels very real to them, but it's coming from an internal source. So hallucinations can also be, they can be auditory, they can be things that they hear, they can also be things that they see, smell, taste, or feel. Hallucinations can also be command in nature. So people with schizophrenia can hear things telling them to do things. So an example that I've heard that I thought was a really good example is someone heard a voice to give away their valuables. So, and those can also vary. They can be a lot of different things that they're being told to do. And then delusions are false beliefs that are very fixed. So there may be evidence to the contrary that those things are not true, but people with schizophrenia often believe them with a lot of intensity. So delusions can vary greatly. So with Tim, when we talked about him, he was having some paranoid delusions. He believed people were out to get him. He believed he was being poisoned. People can also have grandiose delusions where they may believe that they have special powers or abilities that they don't. People can also have somatic delusions where they may believe there's something very wrong with their body that's not actually happening. They can also have referential delusions where they may see something like a license plate and think that there may be a special meaning coming from that, or it could be street signs or things on television or computers that they think they're getting, they maybe think they're getting a special message from. And then people can also think that their thoughts are being broadcasted out for others to hear, or they can also think that thoughts are being inserted into their minds. And this is not an entire list of different kinds of delusions, but these are some of the most common ones. And then disorganized speech. So this can look a lot of different ways, but a lot of times people with schizophrenia, what's really happening is they have disorganized thinking that comes out, that is expressed through language. And so they may rapidly shift from topic to topic. Sometimes we may refer to that as tangentiality, where they're shifting from a lot of different things. They can also have long pauses between what they say. So for example, if you were to ask someone a question, they may take a really long time to respond. And a lot of times we refer to that as thought blocking. And then another thing that can happen is referred to as word salad. And that's where really, if someone were to speak, their sentence would not make sense. So sometimes it can be challenging to understand what a person with schizophrenia is trying to convey. Now that's also not always the case. Sometimes people are very able to convey what they're thinking. And then another thing that's common is disorganized behavior. So people may have trouble finishing a task. I know when I shared the example of Tim, he was starting to have trouble brushing his teeth, activities of daily living, those kind of things. So sometimes people can struggle with those things. They may also have inappropriate laughter or agitation that they would not have had before. And then also catatonia can happen with schizophrenia. So it can look a lot of different ways, but a very broad definition would be a marked decrease in reactivity to their environment. So for example, a person with catatonia, you may call their name and they may not respond. It can also become very severe to the point where they may stop eating. They may require medical intervention if it becomes severe. And then negative symptoms. So there are 5 general symptoms that we think of that are considered negative. So one is reduced emotional expression. So a lot of times they may have a very blunted affect where, I'm kind of using my hands a little bit and maybe smiling some, things like that. Someone with schizophrenia may be less expressive through gestures, through facial features, and it may be difficult to know how they feel. And then lack of motivation is also common. So they may stop doing things that they used to do, like going to school, going to work, turning in homework, things of that nature. And then another common symptom is decreased speech output. So you may ask a person a question and they may give you a one-word answer or a very vague answer to something where in the past they may have been able to share, an extensive sentence with you. And then another common symptom is decreased ability to experience pleasure. So things they used to enjoy, they're no longer enjoying. So for Tim, it was video games. For other people, it could be a lot of different things, but they no longer find enjoyment in activities that they had at one time. And then another common symptom is lack of desire for social engagement. That could be for a lot of different reasons. They may fear other people. They may be experiencing paranoia that causes them to not want to go out. It could also be part of the lack of motivation to go out, but a lot of times people that are experiencing symptoms may withdraw and isolate. And I'll let you.
Thank you, Elizabeth. So as Elizabeth was describing, we've got those positive symptoms, or kind of the hallucinations, delusions, the disorganized behavior, and so forth. And we think about those as being positive, not in the sense that they're good, but in the sense that they are excessive compared to the typical experiences that most people would have. Negative symptoms, not necessarily bad, so to speak. It's not what we mean by negative there. We're kind of referring to that in terms of it's privative in nature. It's a decrease in what most people would experience. But schizophrenia is also not the only type of way in which psychosis may manifest. When we do diagnosis as clinicians, there are certain criteria that we utilize to make definition or to describe different diagnoses. For a person, for example, to be diagnosed with schizophrenia, we have to see some of those symptoms that we just described over a period of 6 months. But some people may also experience psychosis in other ways. So, for example, brief psychotic disorder. We define brief psychotic disorder as people who may be experiencing one or more of those other symptoms that we just went through, but they're within the first month of onset. Now, another thing that's really important for us to look at there, too, is what's also going on around that. So, for example, we'll touch on this in a moment when we look at some risk factors. Marijuana use, unfortunately, is indicated in about half of first episode psychosis. Now, it's not uncommon for a person to experience some type of psychosis when they're intoxicated on marijuana. Those symptoms usually go away relatively quickly. If a person hasn't used and say it's 3 weeks later and they're still experiencing symptoms, then at that point we may say this doesn't look like it's substance-induced. We may be in a brief psychotic disorder at that point. If we move into the next month, we're now in months 2 through 6, and we see the presence of those positive and negative symptoms. At that point, we define that as schizophreniform disorder. Some individuals with schizophreniform disorder will not have further episodes. The same way with folks who have brief psychotic disorder. They may not have further problems after that first month. But if those problems extend into the 6th month, that's when we move into the diagnosis of schizophrenia. Now, we mentioned anhedonia, or that lack of pleasure or interest in doing things. Lack of motivation. Those are also things that sometimes we see in things like depression. And so as diagnosticians, we clinicians, we have to be able to kind of parse out the difference between what are we seeing with somebody. Are we seeing somebody who's dealing with depression? Or are they dealing with psychosis? Or is it possible that they're actually dealing with both? So how we define this is if a person does experience depression, and we have criteria for how we define depression. Generally speaking, we look for 5 out of 9 different symptoms over a 2-week period to define a major depressive episode. If we see a person who experiences psychosis within a depressive episode, then, and it's only within that depressive episode, we may define that as major depressive disorder with psychosis. However, if a person experiences psychosis outside of that mood episode, then at that point, we would define that as schizoaffective disorder, depressive type. Likewise, if a person experiences mania, which is how we define the primary characteristic of bipolar disorder. Mania is a state of being where lasting for several days, usually 4 days or longer, where a person may experience things such as increased energy with decreased need to sleep. There may be a sense of euphoria or increased agitation or irritability, maybe racing thoughts, grandiosity, which is kind of a person maybe thinking they could do things that they really maybe couldn't really do. Maybe they don't have the skill set for, or something along those lines, or a person who gets really into something and thinking they're really good at it without having the skills to do it yet, or the talent to do it. A lot of increased goal-directed activity, often oriented around pleasure-seeking or other highly impulsive or risk-taking behaviors. If we see the psychosis only within that period of time, then we would define that as bipolar disorder of psychosis. But if we see psychosis again outside of a manic episode, then schizoaffective disorder bipolar type would be appropriate diagnosis. So there's a nuance there that, unfortunately, even a lot of clinicians sometimes don't ask that question of when do you experience the psychosis? When do you not experience it? It does make a difference, mostly in distinction, not so much in treatment necessarily. Delusional disorder involves individuals who experience those delusions that Elizabeth described without seeing hallucinations. And then we have this kind of other category. Most things in the DSM, which is the Diagnostic Statistical Manual of Mental Disorders, it's the book that we use to diagnose mental disorders, give us a category that says if a person's experiencing things but they don't quite have enough symptoms, so you can't make a formal diagnosis, or maybe their timeline requirement isn't met, or maybe there's some other factors you need to consider, then we have this kind of catch-all category to say we think something in this class of symptoms is going on. And so this last diagnosis is related to that. So you can see how individuals who are in kind of a first episode of psychosis realistically move through several of these diagnoses depending on where we're at in the timeline. A person may start out with a brief psychotic disorder, and maybe then we move past that first month because they're still experiencing symptoms. Now we're in the schizophreniform disorder. We move past the 6 months. Now we can make a definition, or the diagnosis of schizophrenia. Now throughout all that, we may be treating those disorders very similarly. You can think of it as being a spectrum, again, which is something that is a more recent development in psychiatry. Something that's really been the case over about the past 10 years. Think about a lot of disorders as being something that exists on a spectrum of intensity and symptom severity. So, as I mentioned, psychosis can happen in a variety of different contexts. Like I said, they can occur within mood disorders, like bipolar disorder or depression. They can occur from different brain disorders. So some individuals, for example, may have, we have a person that we've been working with recently who has an autoimmune disorder. And this autoimmune disorder, whenever they have inflammation in their body, and it may be from something as simple as the cold, getting a common cold, they end up manifesting antibodies which lead to them developing psychosis. Once that inflammation comes down, those symptoms tend to go away. So we look for things along those lines. Likewise, things such as temporal lobe epilepsy is something that we may see people may have experienced psychosis with. Substance use. This is one that we often see, unfortunately, and that's where we have to tease out as clinicians what's driving the psychotic behavior, the psychotic experience. Is it a matter of the substance itself, or is it maybe that the substance perhaps opens a door? And that's unfortunately something we tend to see now with marijuana. It appears to be the case that, especially with the heightened THC content that's in marijuana that's commonly available today compared to, say, marijuana back in the 60s and 70s, that for some individuals it seems like this kind of opens the door for them to manifest stress in terms of psychosis. So we look for that. Likewise, we look at certain medications. So many years ago, I was in an emergency room. I'd been called in to talk to a woman who was psychotic. And this is a person, she had a psychiatric history. She was a patient who was being treated, if I recall correctly, for depression, but had no history of psychosis otherwise. She had a medical illness that was being treated with prednisone, a common steroid. Many of you in this room or watching today may have been on prednisone before. Some individuals on a steroid may find that they get more irritable, get more active. This person had active psychosis with that. I remember her very distinctly yelling at me in the emergency room and then immediately apologizing, saying, "This is not how I normally am. I am so sorry." But she was experiencing this agitation associated with it. She was delusional from that, but she had the insight at that point to also recognize this something else going on. Needless to say, my recommendation to the doctor in the emergency room was, I don't think she needs to be on one of our psychiatric units. I think she needs to be treated medically so we can get this under control, because I'm not so sure that this is going to continue. Another thing I'll note here too, this can be pretty important for older folks, unfortunately, is that I've seen in my career a lot of individuals who are older who develop a urinary tract infection. And a UTI can be severely debilitating to folks who are older. I don't know that we have a good idea as to why that's the case, but I've been called into numerous evaluations on medical floors and in emergency rooms to talk to somebody, and they had a UTI and they were psychotic because of the UTI. Get them on an antibiotic, get that infection taken care of, and they're back ready to go home. They did not have that as a lingering problem. Sleep deprivation, likewise, can lead to psychosis as well. This tends to be, varies a lot for folks. Some people, they can maybe be able to go a day without sleep and be fine. Some folks, can't really go much more than 12 hours without sleep. But some people, especially if you go much longer, several days in, it's not uncommon at all for a person to begin experiencing this. So when we look at the onset of psychosis, one thing that's important to note is that psychosis can happen almost at any point, but we do see points of an age where it tends to be more common. For males, early adolescent or late adolescence to early 20s tends to be the most common. For women, between their early 20s and up to their early 30s. Now, because a person has experienced psychosis maybe outside of that time range, that doesn't necessarily mean they may not meet criteria for schizophrenia or one of those other psychotic disorders, but oftentimes, I know for myself, I'm asking, what else may be going on? Has there been a thorough enough medical evaluation to make sure there's not one of those other things that could be happening that could be leading to those symptoms? It's really uncommon to see this diagnosed in people younger than 12 or in people who are older than 40. It is possible, but it is not very common because usually there are these, again, countervening situations. In terms of prevalence, we estimate that about 3 out of every 100 people in their lives will experience some kind of psychotic episode. That's a lot of people. Now, not all those folks are going to need hospitalization. Not all those folks are going to need medication. Sometimes those are situations where a person has been overwhelmed, they've been distressed, they adapt to the stressor, things get better for them, and they're fine. Some folks, however, unfortunately, they won't. They may need that kind of assistance. And we estimate that about 1% of the population in the United States meets criteria for schizophrenia. So think about that. That's about 3.5 million people or so in the United States who meet criteria for schizophrenia. That's not including the other disorders I've just mentioned. There are more people who experience psychosis outside of people diagnosed with schizophrenia than there are necessarily folks who, again, meet that criteria for schizophrenia. So again, about 3 million folks or so. So one thing I also want to highlight, and this is incredibly important, individuals who experience psychosis, for the vast, vast, vast majority of them, they're not dangerous. There's no reason to be worried about them. They are often very scared. They need assistance. They may feel lost. They're not sure what to do next. And if we can bring empathy and compassion to those folks instead of fear, we can really change things dramatically for folks, get them into the right kind of help to be able to help them hopefully get back on their feet and get them back to where they want to be in their lives. So this is something that's important to recognize. This is not uncommon at all. Now, psychosis isn't just, hey, it's Tuesday, a person's psychotic. When we think about psychosis, we talk about these 3 phases of psychosis. And the prodrome phase, this is kind of the insidious phase. What I mean by that is that symptoms, just as Tim's story described, they start out with things that a lot of people don't recognize. In our program, the most common things we hear from families is, I didn't know this was going on. I thought maybe they were depressed. Maybe they're stressed at school. Maybe there's something else going on. I thought they were just busy. And so it slowly develops. And it's during that point where it's slowly developing, we call it the prodromal phase. So you can imagine it kind of like a bell curve. You've got a curve comes up like this and down. So that first part, the prodromal phase, a lot of times folks don't recognize what's happening. Because remember, these are, for the most part, internally generated experiences. These are things that people are experiencing in themselves, right? From the way in which their brain is interpreting information, the way in which the brain is being stimulated and so forth, the way how it's functioning. And most of us don't go around reciting everything that's going on in our heads at the same time, right? I mean, how many of you in this room or online right now are kind of going through and just chattering away with your flow of speech, your stream of consciousness and whatnot, just dictating and narrating the world around you? We don't do that. And so maybe there are these little points where something comes up. A person that we're working with now began experiencing symptoms about in this case, about 15 months ago or so. And her parents said, I remember they said something that was I thought was a little bizarre, but I didn't think about it. I didn't really put it in any sort of context. In this case, this was a person who was in college, so they were away from the family. But it was while they were away from the family that those other symptoms, much like Tim's story, began to come into play. And this leads to this acute or kind of active phase of psychosis. This is what I like to call the public eruption. And what I mean by that is that that's whenever it becomes clear to people around them something's going on. It's possible that they begin responding to some type of internal stimulus. So maybe it seems like they're responding to something they're seeing, maybe that they're hearing. They may seem preoccupied in a way that doesn't make a lot of sense for the environment and the knowledge that you may have about that other person. Or you start seeing those withdrawal symptoms like Elizabeth described. When a person is in this acute phase, this is when the psychosis is kind of at its peak intensity. This is often going to be the time whenever families and folks around them recognize that now we need to intervene. Something's going on. This is the point where people come in to emergency rooms. It's the point where oftentimes law enforcement ends up getting called in. I imagine here at the library, as a public service institution, I imagine sometimes this is the phase where you may see patrons come in. So how we approach somebody in this phase is important. They're in crisis. It's an important thing to remember. They're in crisis. They want and they need help, but they may not be able to effectively articulate and communicate that need for help. Now, for some folks, even outside of getting into active treatment, whether it's hospitalization, medication, therapy, or otherwise, for some folks, they may see just an improvement that kind of naturally happens. This is this kind of recovery phase. Sometimes this, and most likely happens when a person has actually has had some type of intervention. That is, now they're beginning to see a doctor, they're seeing a therapist. Ideally, they're seeing a therapist, in addition to seeing a doctor. There's something that's going on medically for that person. But even in this situation, in this recovery phase, for many individuals, they may continue to experience some residual symptoms. And this is an important thing to recognize. Psychosis is unfortunately not really like a regular light switch with an off-on. Think of psychosis being like a dimmer switch. Sometimes the light's a little dim, sometimes the symptoms are quite low, may not be too impactful. Sometimes they may be much more impactful, much more intense. One of our goals in treatment, ideally, we can hopefully remove the symptoms and the symptoms will go away. But for a lot of our folks who live really well with schizophrenia or with psychosis, they learn to adapt to having a low degree of symptoms. And hopefully, it doesn't cause too many problems for them. Now, one of the biggest questions that comes up, of course, in all psychosis is, why? Tim was a regular college student. What happened? Something must have happened to Tim. Unfortunately, in psychosis, schizophrenia, we never really can point to the one thing. Say this one thing is why this happened. So it's useful to think about a set of risks, risk factors. Some of these are biological. Some of these may be genetic in nature. But when we think about genes, you can imagine genes kind of being like a light switch. I'm going to go back to that in a minute. So a person may carry some type of vulnerability in their genes. And then they've got these environmental things that happen. Maybe it's trauma. Maybe it's substance abuse. Maybe it's some type of environmental stressor, some type of chemical exposure of some type. And that light switch kind of gets flipped on. So all of a sudden now psychosis becomes kind of an avenue for stress to manifest, for symptoms to begin to develop. As I mentioned, marijuana, it's a big one. And this is a factor that, again, we're seeing across the nation, especially with changes in marijuana laws, recreational marijuana, medicinal marijuana, the heightened increase amount of marijuana in terms of THC, as I mentioned. At our conference that we held yesterday here in Fayetteville, or Northwest Arkansas Schizophrenia Conference, one of our persons in the audience pointed out, and this is a person who works with veterans, that some of the veterans that they work with, they use medicinal marijuana. Of course, there's maybe some valid reasons for that. Psychiatrically, very, very limited, very, very, very limited, very, very, very limited evidence of any support of that for anything. But he mentioned, the veterans get a discount at some of these dispensaries. And again, the marijuana of today, not the marijuana of the past. But we do know that marijuana use in adolescence does appear, as said, to be indicated in at least 50% of first episode psychosis. So it seems like, again, it opens the door. Another thing I also want to note associated with this too is that there's been some really interesting evidence coming out about what we call social determinants of health. So what is it about the way in which our culture exists and things that happen in our culture, and how does that lead to people developing certain symptoms or certain types of disorders? There's a really interesting article that came out just last month, actually, in New York Times Magazine about racism and the prevalence of schizophrenia within the African American community, and how much that is out of proportion and out of line with what we would see in many other ethnic groups. We know that poverty can have a role in this. And I mentioned kind of early childhood experiences. Schizophrenia really kind of starts in utero. Now, it may not manifest that way. I'm not saying that fetuses and infants and so forth are schizophrenic, but those risk factors are kind of present. And all these things, all these little stressors, they act to manipulate these expressions that can lead to the development of these illnesses. So I see here the things that we mentioned: vitamin D deficiency, malnutrition, infection, excess stress, gestational diabetes, low birth weight. All these appear to be favorably associated with developing schizophrenia and psychosis.
All right, now I'll talk a little bit about treatment, where we are currently, and maybe a little bit about the past. So I know I've definitely heard lots of stories about people talk about loved ones being institutionalized in the past. And at one point, a lot of people were put into hospitals long term, and that was how this was dealt with. Things have gotten better, I think, in a lot of ways. And so now we're to the point where treatment typically is done on an outpatient basis. There are times when people are experiencing acute episodes where they do need to be hospitalized. But on an outpatient basis, the main treatments are going to be antipsychotic medications along with psychosocial treatments. So antipsychotic medications, they can be given orally where you take them every day. They can also be prescribed as a long-acting injection. So those can be great for people that struggle with remembering to take their medication or with compliance. So a lot of times those are given every 30 days. Sometimes there's a slightly different time frame, but generally it's 2 weeks, 30 days. So they're not having to do it every day. And then psychosocial treatments can include a lot of different things. Something that is really important is just giving people the education that they need to know about their illness, and also giving their families the education that they need to know how to support their loved one. So a lot of times we're doing individual therapy, family therapy, and group therapy. There are some parts of Arkansas where assertive community therapies are available. It's not widespread, but this is where the treatment providers are going out into the community and meeting the person generally at their home, or out in the community where they're not having to come in. And this can be great for people that struggle with keeping their appointments. I wish it was more widespread, but to my knowledge, there are some assertive community treatment options in Little Rock and in Harrison through Arisa Health. And maybe one day they'll be here as well. And then also coordinated specialty care for first episode psychosis. So that is what we do at the Odyssey Clinic. So it involves a lot of different things. I believe I have it on the next slide. Well, actually, I'll talk about it a little bit. I may talk about it in the future too. But we offer basically a wraparound service. So we're offering individual therapy, family psychoeducation and support, supportive education and employment services, case management, and medication management. And that's been shown to be one of the best treatments for people with first episode psychosis. And then some common barriers to treatment can include a lot of different things. Craig talked about this a little bit. Sometimes families don't recognize that the person is having those symptoms. I've also heard from a lot of families, I noticed something was different, but I didn't know what it was. So that is very common. And then not knowing where to seek care is another common issue. It can be very, very difficult to know where to find treatment at times. And then another thing that I think we probably see a lot is stigma. I've heard it from patients and their family members where people still call people crazy. You know, people say really mean things. And it's something that I think we all play a role in, is having an awareness and ending that stigma, because it is truly something that delays people from seeking treatment. So we all play a role in that. And then another big thing that's very important for people to know is a term called anosognosia. So this is a lack of awareness or insight into their illness. It's very common. So with people with schizophrenia, about 50% or more experience this. So it can often look like they may not realize how their illness is impacting them. They may not see that there are any deficits in their functioning. So it's not that they're denying it necessarily. It's that they truly don't see that they are experiencing these things. And then, let's see. Craig talked about this a little bit, some misconceptions. So I think this is another important thing with ending the stigma. So is changing our perception of schizophrenia and not continuing to think these things. And that comes with just education and awareness. So Craig shared, there is a common thought that people with schizophrenia are dangerous. People with schizophrenia are actually much more likely to be a victim of a crime than a perpetrator. Another common misconception is that people with schizophrenia can't hold down a job or can't work. There was a study done at UCLA where they took people that were newly diagnosed and they gave them the treatment that they needed. And within 6 months, 83% of them had returned to work. Now, some of them had accommodations to help them with their employment, but they were able to go back to work. And then another common misconception is that people with schizophrenia cannot recover. So like Craig mentioned, there's a dimmer switch. Some of it, they may still have symptoms. When we think about recovery, it's not necessarily that there are no symptoms, but it's that they've learned how to live and live well with their diagnosis. And then, so I'll talk about this a little bit. The importance of early intervention is really key. So this was actually very shocking to me to know this number, but the average duration of untreated psychosis. So the amount of time that a person goes before they ever seek treatment in the United States is 74 months. That is an incredibly long time. Oh, I'm sorry, 74 weeks, I'm sorry. That is a year and a half. That's an incredibly long time to go without treatment. And what research shows is that a shorter duration is associated with better outcomes, including remission of symptoms and improved quality of life. So also you're seeing reduced hospitalizations. So the sooner people can get treatment, the better. The World Health Organization recommends starting treatment within the first 3 months. Now, that can be really challenging because, like we talked about, a lot of times people don't have the awareness, and that's where the education comes in, and it's really important for everyone to know the symptoms so that they can help the people in their lives get treatment.
So we at the Odyssey Clinic, we're a relatively new program. In fact, we just got our start last year, but the roots of the Odyssey Clinic actually go back quite a ways. So internationally, coordinated specialty care programs existed for at least 20 years before they really kind of came to the United States. It was in 2008 that the National Institute for Health created the RAISE study, or the Recovery After Initial Schizophrenia Episode study, to look at both the effectiveness and the feasibility of doing coordinated specialty care in the United States. This project identified 17 sites where they performed this coordinated specialty care and compared that to the results that they saw in 17 sites where they did treatment as usual, kind of the normal outpatient care that individuals with first episode schizophrenia or first episode psychosis may have. And what they found was that in that period of time, a lot of good things happened. Most people were able to return back to work, or they were able to return back to school. They improved higher quality of life. That improved for them. With family involvement, and this is important, family involvement, the family voice, the family experience was taken very seriously. And it's taken very seriously in our program and in coordinated specialty care programs. That's the reason why we do so much psychoeducation and support for families. Because remember, when psychosis happens, it's not just happening to the individual who's experiencing it. The family is also dealing with this. It's like a grenade has just gone off in the home. And then everybody has to figure out, what do we do with this? How do we adjust to it? How do we figure this out? How do we deal with the grief associated with this? So when you have families involved, things such as hospitalization rates, days and so forth, dropped by like 60%. Tremendously. Likewise, intensity of symptoms reduced quite a bit. This was stuff that came out of the RAISE study. And out of the RAISE study, there were two primary different interventions that came out of that. The Navigate system and then the On-Track system. Both of them basically do the same kind of thing. There's some distinctions between them, but they all involve these elements of coordinated specialty care. These are some of the things that Elizabeth mentioned earlier. So the individual therapy that we do in coordinated specialty care, it's a little different than your standard therapy. It's kind of a mixture of of a model we call illness management recovery and cognitive behavioral therapy for psychosis. But we also look at other things too. We want to educate our clients about psychosis. We want them to understand what they're experiencing and be able to describe it and to be able to understand the reasons why it's important and why it's useful to seek treatment, how to stay in treatment, how to remain adherent to treatment and the benefits of doing so. We go over several different other topics. These include things like how to live a healthy lifestyle. How do you deal with stress? How do you deal with the trauma associated with the psychotic experience? Think about, for our clients, their lives looked one way, and then they looked very, very different. And a lot of times after that, they're saying, what happened? And so they're trying to make sense of that, and we help them learn how to do that as well. As I mentioned, we work with the families. We want the families to understand these same things. What are their loved ones going through? What are they going through? We want to give them opportunities to talk and process and work through their experience of what they're experiencing with their loved one. But we also want them to learn how to be supportive in the right kind of ways. Working with a family recently, and the family was doing all the things that they knew to do. I'm not saying they were doing bad things, but once they recognized elements of the anosognosia that their child had, that their loved one had. They realized that that lack of insight was causing problems. We were able to introduce them to a different way of working with that. And I remember Mom very distinctly saying, I've been doing this all wrong. She was a loving mom. She was doing what she knew to do. But we were able to give her and get her to the skills that she needed to do what her son needed. And we'll keep working with them. And we'll keep working with them. Medication management. An amazing thing in coordinated specialty care and first episode psychosis. Most of our clients, once we get it on the right medication, get a lot better within 3 to 4 months. A lot better. Now, sometimes getting to the right medication, that can sometimes take a little bit because some folks don't respond well to certain medications or they have side effects and we want to find another medication which doesn't have those side effects and so forth. But again, 3 or 4 months across most of the antipsychotics that are available. There's not really much of a distinction there. You got differences in some of the side effect profiles and so forth, but that's really, really impressive. Supported employment and education services. So one of the important things in our program is we want to help our clients develop, obtain, and maintain academic and vocational success. Remember what I mentioned about those ages of onset? What's happening with people in late adolescence and early adulthood? They're moving on from their family of origin home, right? They've gone to college maybe, they've moved out, they're in the workforce. They got a lot of things that are happening. They're becoming adults, they're entering into the adult world. And then this happens, and that disrupts them. In our program, we want those people to get back on track. We want to help them find their way home, so to speak, like Odysseus in the Odyssey. He got lost on his way home. It took him 10 years. But he had help along the way. And some comic and not so comic misadventures, but read the Odyssey. It's a great, great classic text if you haven't read it. But our supported employment education specialists help our clients do this. And so some of our clients, they're still in high school. And so we're working alongside their school and their teachers, guidance counselors, principals, and so forth, to help them get the accommodations that they may need to be able to do well in class. Or if they're in college, we're working along with disability support services that the university offers. We may be talking to professors. Again, this is all with our clients' permission, of course, to help them learn how to adapt well to classes. Or if we have people who are entering into the workforce. How many of you remember knowing how to do a resume, first resume you ever did? First application you ever filled out, knew exactly what to put out? Some folks, they're just getting into it, so they're dealing with this for the first time. So we help them learn how to do those things. Or going to that first interview and not being quite sure how to answer those questions. Feeling really intimidated from the person who maybe holds your life, so to speak, maybe in their hands, whether they give you the job or don't give you the job. So we help them do that. But along with that, in developing those skills for how to interview, how to do job searches, how to write a resume, things along those lines, we also want to help people figure out, well, what do they want to do? So looking at what are their interests, what are possible jobs associated with those interests. But we also want to work alongside employers. We want to help employers know that they've got an employee who could be a great employee. And that employee is getting some additional supports. We want Bob, who goes to the office, who may be experiencing psychosis, to just be Bob in the office. And so when we work alongside employers, they know how to be present there. And then if there are things that they notice, they reach out to us too, and then we can maybe work with Bob, so to speak, and help him, again, stay on track. And we also offer case management services. So sometimes our clients have needs, like anybody. They may be dealing with challenges with insurance, or maybe food insecurity, or housing insecurity. And so we also offer those kind of services within coordinated specialty care. Some programs also have peer support specialists, which are incredibly beneficial. We are hoping to develop that further here in the state of Arkansas. We have peer support specialists for substance abuse treatment. We're still working on the rules and so forth and the regulations for mental health peer support. They tried to mimic what they did with substance abuse, and they realized mental health is a different animal, different game. They need to do something a little different. So they're in process on that. The On Track program, which is one of those other programs that came out of the RAISE study, they bring peer support into it. And there are also some programs out there that also have family peer support. So they have a family that's some point further down and their loved one's experience. And they're there to help other families go through their experience. So there's some really exciting things that are out there in coordinated specialty care. So I mentioned these various elements of the Odyssey Clinic. The Odyssey Clinic is an outpatient program that we have, again, in Little Rock as well as here in Fayetteville. And we are a 2-year program. So folks can come to see us for up to 2 years, though some people may continue to benefit from us a little bit later than that. That's okay. We're an outpatient program, as I said, so people come to see us in the clinic, but also we also work with folks via telemedicine. We also, in some situations, may need to go see somebody in their home. They don't want barriers to access to be a problem. So we try to help people wherever they're at. Another really important element here, and I cannot highlight this enough, shared decision making. We as clinicians and as professionals, we're not the expert in the room of our client's experience. Our client's voice is important. It's the most important voice in the room. Their families, their loved ones, they are vitally important. Whoever the client identifies as being that support. We want to empower our clients to be a full partner in their health care. So we're not there to say, you got to take your medicine. We're not there to say, you need to, you must. We're there to work collaboratively and in partnership with our folks. And that's incredibly valuable. When people feel like they are invested and part of their treatment and part of their treatment team, they get better.
All right, I just wanted to touch on this really quick. I know we have a few minutes left, so I think a really important thing is just where can you find support if you know someone that does have schizophrenia. So NAMI up here in Northwest Arkansas, they have a family support group. It is the second Monday of each month, and it's actually located within the Ozark Guidance Center in Springdale. So it's open to anyone can go to that. And that's not just for schizophrenia, that's for any mental illness. But it is a support, and I think it's a very good one. And then NAMI Arkansas also has a virtual support group, and that's open to anyone as well. So that could be the person experiencing the illness, it could be anyone. And then I also put some websites on here in case you do know somebody that is needing support. So findtreatment.gov is a really good resource. So you can go on there and put where you live, and options will come up. Arisa Health, as I mentioned earlier, they do have assertive community treatment in some areas, and locally they have some day treatment options for people with schizophrenia. So they are the community mental health agency in this area. So it's also known as Ozark Guidance Center. They go by two names. But they are the local community mental health center, and so they have a lot of resources as well. And then I also put our website, our clinic phone number, and our email addresses. So if you do have, if you ever want to reach out in the future, you can definitely reach out to us, and we would be happy to help you guys find support if you need it. And then lastly, I did just want to share, people do get better. And I thought I'd highlight a couple of stories of people that have done really well in recovery, and they've actually written books. So Ellen Sachs is a professor of law, psychology, and psychiatry at the University of Southern California. She has schizophrenia. She didn't share her story for a while, and then she did, and it's an amazing story. And she has went many, many years without needing hospitalization. And she wrote a very, very excellent book called The Center Cannot Hold. And then Bethany Yeiser, She actually was homeless for 4 years while she was experiencing symptoms. And when she finally got treatment, her psychiatrist got her on the right medication, which was Clozaril, and they actually founded a research kind of foundation together to help people get more education about underutilized medications for schizophrenia. And she wrote a book called Mind Estranged, My Journey from Schizophrenia and Homelessness to Recovery. So just wanted to highlight people do get better. And I think we have a little bit of time for questions if you guys have any.
Yeah, you mentioned like if you have somebody, schizophrenia or psychosis, and they don't really think they have a problem. Okay, you said like the mom was kind of going, oh wow, we've been doing it all wrong. So like, can you give a little bit more of what the right way to talk to somebody who is thinking that they don't really have a problem? I've got a daughter who's kind of wanting to drive, and I mean, sometimes her episodes are pretty intense, I guess.
Certainly. One of the world's leading experts on agnosia, this lack of insight and awareness, is named Javier Amador. The Xavier, last name Amador, Amador. And I think he wrote an excellent book called I'm Not Sick, I Don't Need Help, in which he describes what he calls the LEAP model, or the LEAP model. Please help me remember all the acronym.
It's listen, empathize, agree, partner.
Agree and partner, that's right. And so the idea there is when we confront somebody who is ill and who doesn't believe that they're ill, you're likely to create a conflict, right? How many of us do well in conflict? None of us, right? Really? So instead, when we can listen to somebody and try to understand their need, and try to recognize and empathize with that need that they have, and then we can partner with them to try to meet that need. Oftentimes, that's whenever we can kind of, I would dare say, a little subtly, we can begin to get in there and maybe get the person around to recognize that maybe there is something going on. Or maybe that there is another option than the option that they're moving down, the track they're going down.
Right.
And so, oftentimes it's a slow process, which can be really frustrating, especially when we have a loved one in distress, and we're in distress. We want help now. We want to get things done now. But we know that's not how it works. And so, very much so, finding those areas of partnership, and kind of working towards those. And sometimes we have to start small and work our way towards the big thing. Sometimes we get there in jumps that we don't expect. But this process is one that I found to be incredibly beneficial. And again, his text, I'm not sick, I don't need help, really brilliant. Again, his name, Javier Amador.
Do you find that schizophrenia is a progressive disease?
The question is, do we find that schizophrenia is a progressive disease? Actually, schizophrenia tends to get better over time. Now, that doesn't mean it gets to the point where there's nothing going on, but a lot of times the symptom intensity really is more front-loaded in the illness, and over time, the symptoms do tend to mellow to some extent.
Even unmedicated?
Even unmedicated.
So they're adapting?
Yes, people, they kind of adapt over time. And one thing to always remember is that for all of us, we're always trying to figure out our strategies for negotiating our world, right? And so we adapt. We try to figure out things that work for us, things that don't work for us. Sometimes we're not so good at recognizing things that don't work for us, but people do begin to adapt. Sometimes for some individuals, they may also do a lot of masking too. So sometimes people may still be in some distress, but they've learned that maybe if they show that distress, that they're not going to get what they want. They're not going to get the help that they need. And that sometimes can look like they're doing better when they might not be.
You said that people do best if they're recognized and treated within 2 years. What about someone who's had it for decades? Is there still treatment available locally who might decide they will try something?
Yeah, so the question was, we talked a lot about the first 2 years of within the illness. What about folks who have been dealing with this for longer, other treatment within the community? There is. Places like ERISA, again, as a community mental health provider, those are the folks who are really kind of experts at working with multi-episode or long-term chronic illness. So places like that, we at UAMS, our psychiatrists in our psychiatry department, we have folks who are experienced in working with individuals as well. And there are some private providers out there, some private practice providers who are also quite good at doing this. So it is possible, definitely for people who receive assistance. Some people can do things on an outpatient basis. I've seen some folks who go to day treatment programs and can work from there. And those kind of models, I've seen some folks, even with long-term illness, go decades without hospitalization. Before I came to UAMS, I worked in community mental health down in Saline County, just south of Little Rock, and Stride House, which was the community support program we had for individuals with severe mental illness. We had many clients. I had several clients who had gone 30 plus years without any sort of hospitalization because they were getting the right treatment. Some of those folks would go every day to Stride House. Some of those folks would go once a week. Some folks would go, every once in a while because they had other things going on in their lives. Many of them were working, or they were in school, or they were doing other things that were just meaningful to them. So there are definitely those options that are out there.
One of the psychiatrists for my daughter actually, kind of opposite of what you just said, she actually said that she's worked with people within 5 years who, they were able to speak, and after 5 years, not even able to make a sentence. She said especially if they don't get the right treatment and they don't get family support. She was talking a lot about my daughter. And so, yeah, that problem, not good at all.
Right. The comment was that there are some individuals, and a doctor had mentioned that some folks can have more disintegration kind of over time. They end up becoming more compromised. We do know that for some individuals that does happen. Without treatment, some people do get better. But as Elizabeth mentioned at the beginning, people vary. And for some folks, especially when there are repeated psychotic episodes or more pronounced, prolonged psychotic episodes, that can lead to further failure or disability, I should say, further challenges. And so it does vary tremendously. We know that helping is always beneficial, and that's what we really want to focus on, because this is not the kind of thing where, generally speaking, doing nothing works out.
It seems like the family really has to get involved because the person doesn't even think they have a problem.
Family involvement is, and what we've seen is essential. Now, some folks can do okay without family. Some people found family and can find good supportive environments and so forth, good supports. But the more people that we can bring together to help support anybody, the better we all do. I always like to think about, if I'm walking a tightrope, I probably want a pretty good safety net underneath me, right? I don't want it to be, I'm on a tightrope, and then there's one line underneath me, and I hope that one line catches me if I fall. So if we have a good support network there, and that may involve the family, it may involve friends, it may involve treatment teams, it may involve your church, your spiritual community, it may involve other types of social groups that people are involved in, that we know that ends up being beneficial for everybody, psychosis notwithstanding.
Thank you all for being here. Again, if you've got questions, please step to the back and we can talk. And we have resources here at the library if you want books or anything like that. We've got the reference desk upstairs can help you find the areas for those and if you wanted more reading on your own as well. Thank you again for being with us today.
Thank you all for